let's turn to previously treated patients with advanced non-small cell. This is really focusing on the patients without a driver mutation. One of the more provocative presentations was from the so-called lung map study, which is a sprawling ongoing campaign really of switching out different questions in patients who have previously treated advanced lung cancer. And you can adapt to study many different types of questions with different targets. This one was looking at pembrolizumab or Keytruda immunotherapy combined with an anti-VEGF or anti-angiogenic therapy to target the blood supply of the cancer. And in fact, this agent Cyramza or ramucirumab is a component of treatment that we routinely give with Taxotere, older chemotherapy that's been around as a standard treatment for lung cancer for 25 years. And it's routinely used in the second line setting. So this was in patients who had previously been on chemo and immunotherapy and had been on them for at least essentially 3 months, 84 days. So not looking at people whose cancer had exploded through treatment, but rather those who were on these treatments for a while and then either were randomized to Keytruda with Cyramza or a dealer's choice of various options that the physician could select. It was not an enormous study. It was not the definitive study, but it was designed to ask, does this look promising enough to study in a larger setting? And that was 136 patients randomized to one or the other, did not show a significant difference in progression-free survival, but it did show a significant improvement in overall survival with an approximately 3-month difference in median overall survival, the time before half of the patients in each group had died. And you can see in this slide here, the range of treatments that people actually received was at the bottom. I think one thing that is a credit to this is that so many of the patients did get the best treatment that we have, which is docetaxel, Taxotere, and Cyramza. And so that kind of controls for the component of what the Cyramza is doing. At the same time, most of our trials in the second line and later setting don't give that. They don't give the best that we have. And I think that's a limitation. I would say a challenge of this is that gemcitabine or Gemzar is one that we like giving. It's well tolerated, but it doesn't have proven efficacy beyond giving a placebo or hugs. And obviously no treatment was given to 6. So 18 of the patients on the standard of care arm got something that does not have clear efficacy at all. And I think that's somewhat of a limitation. The side effect profile, all the stuff on the top of this slide is really just to say that the side effects were greater in most cases with the chemo, which is not surprising. That the chemo-based, especially Taxotere, is not one that we relish giving because it's easy to give or easy to take. It's one that we somewhat give through clenched teeth because it works, but it's not enhancing most people's quality of life. So, and you lose your hair and various other things. So it causes fatigue and diminished blood counts, et cetera. So now, so this study was a positive study. The commentary from an expert at ASCO suggested that this could arguably change the standard of care. I did not feel that that was the case myself. I thought that was premature, and I don't think that that's slandering the study. It's just, and this was actually also published in the Journal of Clinical Oncology same day. Important study, but in my mind, not clearly one that is big enough or definitive enough to change the standard of care now. But I don't want to decide. These are drugs that are commercially available. Does argue that a subset of patients who had prior progression on immunotherapy, still could be juice in that if you go back to it. So maybe I could start with you, Jarushka, and get your thoughts on what did you personally think of this? What do you think should be a broad policy of what we do with this information?
I think, like you, I had a visceral response to hearing this is practice changing, because I did not feel that it was practice changing. So I think, well, I do think they're exciting though, and I don't want to minimize the work of the teams and obviously the patients who participated. So I think that this is definitely a combination to watch, but it is in a small number of patients, and it is a phase 2 study. So it's not really of sufficient, it's not at a sufficient stage in its development, I think, to be practice changing. The other thing is, in my mind, this is probably one of the single biggest areas of need in lung cancer. What do we do after progression on chemoimmunotherapy previously? So this really has large implications for a substantial portion of patients. So I think, doing a phase 3 study in this setting is very, very important. I agree with you that toxicity, was reassuring. And I think the other factor here is this is a chemotherapy-free combination. So that is something else to sort of take home, is that, we are evolving to have more chemotherapy-free options in our treatment armamentarium in lung cancer, which I think is a great thing. Gilberto, your thoughts?
I agree. The only thing I would like to mention is that when we look at the median survivals in excess of 11 months in the standard arm and 3 months beyond that in the experimental arm, this is a testament of how long our treatments have come. It's still not quite where we should be, but this is much better than the 6 months or so we used to see in trials 10, 15 years ago. So this is already an improvement. It's quite clearly not enough of an improvement yet. And I agree with you, this is our biggest area of need for people who receive chemotherapy and immunotherapy, and then the treatment stops working or doesn't work for long. This is the biggest area of need we have today.
Excellent. Well, thank you both for that. I think we're going to see the results from a phase 3 study. It needs that. And, I think it could very well change practice. I just think we need more data before jumping into that approach.
I would bet on that, but I wouldn't start using it just yet.